Now coming to the intravenous anesthetics, they can be faster acting drugs that are mainly used for the induction of general anesthesia and the slower acting drugs. Now faster acting drugs, basically these drugs when injected intravenously, they produce unconsciousness in one arm brain circulation time. এই arm brain circulation time মানে কি হয়? মানে the time taken for the blood to reach from the arm to the brain, one cycle, it is around 11 seconds. So these are drugs generally which on intravenous injection produce loss of consciousness in one arm brain circulation time, that is around 11 seconds. They are generally used for induction of anesthesia. What do we mean by induction? Induction মানে কি? একটা পেশেন্টকে অপারেশন করার আগে তো ওকে আনকনসিয়াস করতে হবে। So induction means the rapidity with which the anesthesia is achieved in a person to take up for the operation or any surgical procedure. Okay, so they are generally used for induction because of rapidity of the onset of action. Anesthesia is then usually maintained by an inhalational agent. Patient के faster acting intravenous agent দিয়ে আগে induce করে দিলাম, তারপরে to maintain the anesthesia generally we prefer to use inhalational agent. Okay, they are also served to reduce the amount of maintenance anesthetic, and in case of short surgical procedure they can be solely used along with the analgesic and the muscle relaxant. Now coming to the faster acting drugs one by one, mainly two drugs are there, Thiopentone Sodium and Propofol. Thiopentone Sodium is an ultra short acting barbiturate. It is highly water soluble and turns water alkaline, and it has to be freshly prepared before injecting to the patient. Now extravasation of the solution can cause necrosis, pain and even gangrene. Injected intravenously, it can produce unconsciousness in 15 to 20 seconds. Because its undissociated form has high lipid solubility and it enters the brain instantaneously when injected intravenously. Now the initial distribution of the drug depends on the organ blood flow. As the brain is highly vascular organ, brain take up most of the drug and the patient become unconscious rapidly, but later on the drug is taken up by lesser vascular organs like fat and adipose tissue. As a result, as the drug is taken up by the lesser vascular tissue, the blood concentration falls and the drug in the brain they return back to the blood due to the fall in concentration in the blood, and due to redistribution the consciousness is regained in 6 to 10 minutes. The distribution half life is around 3 minutes. But on repeated injection, basically the extracerebral sites, they gradually filled up. Lower doses are used to produce anesthesia which lasts longer. As the extracerebral sites like fat and adipose tissue, they take up the drug and get saturated. Now no drug is going to the lesser vascular tissue, and hence even smaller dose can produce the anesthesia which lasts longer. Its ultimate disposal occurs by hepatic metabolism. Now the residual CNS depression may persist for more than 12 hours. So a person who have been given thiopentone sodium should not be allowed to leave the hospital in 12 hours without an attendant. It is a poor analgesic, so it's a painful procedure. If it has to be carried out on thiopentone sodium, an opioid or nitrous oxide has to be given, an analgesic has to be given. Otherwise, the patient may struggle, shout, and so reflex increase in blood pressure, respiration and heart rate. Now, it is a poor analgesic, it is a poor muscle relaxant. It does not irritate airway passage. Respiratory depression can be significant but transient, but larger doses can produce severe respiratory depression. Blood pressure may fall due to vasodilatation, and cardiovascular collapse may occur if the patient is hypotensive or hypovolemic or in shock. Reflex tachycardia occurs due to fall in blood pressure, but thiopentone does not sensitize the heart to adrenaline, unlike halothane. Arrhythmias are rare. The cerebral perfusion is maintained. Cerebral blood flow decrease due to cerebral vasoconstriction and due to fall in blood pressure. But the cerebral perfusion is maintained as along with the fall in decrease in cerebral blood flow, the cerebral O2 consumption is also decreased. As a result, cerebral perfusion is maintained. Thiopentone sodium is a commonly used inducing agent. It can be employed as a sole anesthetic for the short procedure that are not painful. Adverse effect laryngospasm may occur due to respiratory secretions or if other irritants are there, or when intubation is attempted in light anesthesia. As a result, this can be prevented by atropine pre-medication so that respiratory secretion can be decreased, and administration of succinylcholine muscle relaxant immediately after thiopentone. Succinylcholine and thiopentone, they react chemically, so they should not be mixed in the same syringe. During recovery after injection of thiopentone sodium, shivering and delirium can occur. Post-operatively, pain can be there which can induce restlessness. Adequate analgesia should be provided to cover up the pain. Post-anesthetic nausea and vomiting are not uncommon. It can precipitate acute intermittent porphyria and should not be used in susceptible patients. It is used to it can also be used to rapidly control convulsions, and gradual intravenous infusion of sub-anesthetic dose can be used in psychiatric patient for verbal communication and for narco-analysis of criminals. Now, Propofol is another fast-acting intravenous general anesthetic. It is benzodiazepine used for both induction as well as maintenance. It is an oily liquid employed as a 1% emulsion. Now, patient become unconscious in 15 to 45 seconds and the unconsciousness lasts for 5 to 10 minutes. They distribute rapidly, distribution half-life 2 to 4 minutes, elimination half-life around 100 minutes, and their duration of action is shorter than that of thiopentone due to rapid metabolism. Intermittent injection or continuous IV infusion can be used for total intravenous anesthesia, that means for induction as well as maintenance, when supplemented by fentanyl. Why fentanyl? Because poor analgesic. It lacks airway irritancy and is not likely to produce bronchospasm. They are preferred in asthmatics. It is particularly suited for outpatient surgery. Now, patient acceptability is very good. Incidence of post-operative nausea and vomiting are lesser. Induction apnea for about 1 minute is common. Now, maintenance anesthesia with Propofol produces dose-dependent respiratory depression, which is more marked than with thiopentone. Cerebral perfusion is maintained like that of thiopentone sodium. In sub-anesthetic dose, it is a drug of choice for sedating intubated patient in ICU settings. For However, it is not used for in children, and prolonged administration can cause severe metabolic acidosis, lipemia and heart failure. Now coming to the slower acting intravenous drugs, it can be benzodiazepines, ketamine, fentanyl and dexmedetomidine. আচ্ছা, ফাস্ট অ্যাক্টিং আইভি এজেন্ট কী কী আছে? ফাস্ট অ্যাক্টিং ইন্ট্রাভেনাস জেনারেল অ্যানেস্থেটিক্স, প্রোপোফল আছে, আর এখানে আর কি আছে রে? তাকা এখানে মোবাইলটা দেখছিস, তবে কি দেখছিস? ওপরে কর, বইটা কেন খুলেছিস? প্রোপোফল, থায়োপেন্টন সোডিয়াম, ঠিক আছে। মেনলি ইউজটা কোথায় আছে থায়োপেন্টনে? for induction of anesthesia. Okay. Now slower acting drugs, these can be benzodiazepines, ketamine, fentanyl, dexmedetomidine. Coming to benzodiazepines, benzodiazepines can be used for pre-anesthetic medication. Pre-anesthetic medication माने? Before anesthesia. The drugs which are given before anesthesia so that anesthetic dose can be decreased or anesthesia can be hastened. So in addition to pre-anesthetic medication, benzodiazepines are also used for inducing, for maintaining and supplementing anesthesia. It can also be used for conscious sedation. এটা পরে আসবো আমরা। Relatively larger doses of diazepam when injected intravenously produce sedation, amnesia and the person become unconscious in 5 to 10 minutes. If no other drug is given, the patient become responsive in 1 hour, but amnesia persists for 2 to 3 hours and the patient is sedated for 6 hours or so. Now recovery is further delayed if the larger doses of drug is given. Benzodiazepines are again poor analgesic, so if a painful procedure has to be carried out, either opioid or nitrous oxide should be added. They do not depress markedly respiration, cardiac contractility or blood pressure. They decrease the muscle tone by central action, but the muscle relaxation is not so marked to carry out surgical procedures, and hence muscle relaxant has to be added to attain the muscle relaxation of surgical grade. They do not provoke post-operative nausea or vomiting. They are preferred for endoscopies, for cardiac catheterization, for angiographies, for conscious sedation during local or regional anesthesia, in case of fracture, electroconvulsive therapy. They are also a frequent component of balanced anesthesia. Balanced anesthesia মানে এখানে অনেকগুলো ড্রাগ ইউজ করা হয়, তার পারপাসটা ডিফারেন্ট রয়েছে। লাইক ফাস্টার অ্যাক্টিং ড্রাগ টু ইন্ডিউস অ্যানেস্থেসিয়া, মেনটেন্যান্সের জন্য ইনহেলেশন ইন্ট্রাভেনাস ইনহেলেশন অ্যানেস্থেটিক ইউজ করা হয়, তার সঙ্গে অ্যান্টিএমেটিক্স, তার সঙ্গে তোমার বেসিক্যালি এটা বেনজোডায়াজেপিন ইউজ করতে হয়। তো many drugs are used simultaneously to induce and maintain anesthesia, so that a smaller amount of anesthetic dose is required of each of the component. So benzodiazepine antidote is flumazenil. Now diazepam, lorazepam, midazolam, these are some of the benzodiazepines that are used for anesthetic purpose. Coming to lorazepam, it is 3 times more potent, slower acting and lesser irritant. It distributes more gradually, awakening may be delayed, amnesia is more profound. Midazolam, it is less irritating or non-irritating to veins, water soluble, faster acting and shorter acting, 3 times more potent, fall in blood pressure is somewhat more than compared to the diazepam, and they are preferred over diazepam for anesthetic purpose. They are used for sedation of intubated and mechanically ventilated patients, and in other critical care anesthesia. Now coming to ketamine. Ketamine is another short acting intravenous anesthetic that produce dissociative anesthesia. Dissociative anesthesia means the person is conscious but does not feel the pain, as if the patient is dissociated from his body and the surroundings. What happens here? The patient eyes remain open, swallowing movements are there, muscles become stiffened, and he is not able to process sensory stimuli or respond to it. Person শুয়ে আছে, surgical operation can be carried out, the patient is conscious, laryngeal reflex and other safety reflex are maintained, and patient does not feel the pain or respond to it. The primary site of action is in the cortex and subcortical area, not in the reticular activating system, so patient remain conscious for that. Respiration is not depressed, bronchi dilate, there is dilatation. So this drug is preferred in asthmatic patient. Airway reflexes are maintained, muscle tone is increased, and patient on ketamine show non-purposive limb movement. Heart rate, cardiac output and blood pressure are elevated due to sympathetic stimulation. So this drug is favorable in hypotensive subjects, in patients in shock, they are preferred. A dose of 1 to 2 milligram per kg IV or 3 to 5 milligram per kg IM, they produces the above effect within a minute. Recovery occurs in 10 to 15 minutes, but the patient remain amnesic for 1 to 2 hours. During recovery, 50% of the patients show emergence delirium, hallucination and involuntary movements. They are preferred for operations on the head and neck in patients who have bled. Keno? Jade bleeding hocche, the patient is more prone to go to the hypovolemic shock, and this drug ketamine, they increase the blood pressure because of sympathetic stimulation. So they are preferred in patients who have bled. They are preferred in asthmatics because they dilate the bronchi, they relieve bronchospasm, and in those who do not want to lose consciousness and for short operations. They are also preferred for burn dressings. Okay. Combined with diazepam, they can be used in angiographies, cardiac catheterization and trauma surgery. They are dangerous and should not be used in hypertensive subjects. Dangerous hypertensive crisis can occur. They are not used in ischemic heart disease, as acute myocardial infarction may occur. They are not used in congestive heart failure, it may exaggerate, and in those with raised intracranial pressure, it increases the intracerebral pressure, but is good in hypovolemic patients. Coming to the next drug, fentanyl. Fentanyl basically is an opioid, short acting opioid. It is highly lipophilic, short acting, around 30 to 50 minutes, given intravenously at the beginning of any painful surgical procedure. Now it is frequently used to supplement anesthetics for balanced anesthesia. It basically used kora hoy for analgesic action. Combined with benzodiazepines, it can obviate the need for inhalational anesthetics for diagnostic, endoscopic, short surgical procedures, angiographies, and in poor risk patients and in burn dressing. Anesthetic awareness with dreadful recall is a risk. Respiratory depression is marked but predictable. The patient can be encouraged to breathe and assisted ventilation can be provided. Now with the use of fentanyl on rapid intravenous injection, the tone of chest muscles can be increased and the masseter muscle tone increases. So a muscle relaxant is then required to facilitate mechanical ventilation. Now heart rate decreases because fentanyl stimulates vagus nerve. Fall in blood pressure is slight, but heart is not sensitized to adrenaline, unlike halothane which sensitizes heart to adrenaline. cerebral blood flow and O2 consumption are slightly decreased. Now, to maintain the analgesic action, fentanyl has to be given every 30 minutes or so. Now, but recovery is prolonged after repeated dosing. And antagonist ki ache for fentanyl? Opioid antagonist ki hoy? Class hoyni na opioid naloxone. Okay, it comes under the opioid, so the antagonist is naloxone. So the opioid antagonist naloxone can be used to counteract persisting respiratory depression and mental clouding. On prolonged administration, to regain the if the patient respiratory depression occurs, to counteract that, naloxone can be used here. Fentanyl is also employed as an adjunct to spinal or nerve block anesthesia and in post-operative pain. Now coming to the conscious sedation, as the name suggests, basically it is used in the patient where the patient is conscious. So it is a monitored state of altered consciousness that is employed to carry out diagnostic, short therapeutic or dental procedure in apprehensive subject, jara bhoy khacche ki hobe, in apprehensive subjects or medically compromised subjects jekhane complication of general anesthesia is high, in place of general anesthesia. Now it allows the operative procedure to be performed with minimal physiologic and psychological stress. Now is a state of CNS depression where patient is not unconscious, sufficient to withstand the trespass or stress of the procedure while maintaining communication with the patient. Patient conscious থাকবে, communicate করতে পারবে, কিন্তু patient basically feel করবে না surgical procedure গুলো. So who at the same time respond to the command and is able to maintain a patent airway. The opioid the difference between conscious sedation and anesthesia is of degree. Okay. The protective airway and other reflexes are not lost, making it safer. The drugs that are commonly employed for conscious sedation are Diazepam, Propofol, nitrous oxide and Fentanyl. Now complications of general anesthesia, it can occur during the anesthesia, it can occur after the anesthesia. So what are the complications during anesthesia? Respiratory depression can occur, that can lead to hypercarbia or collection of carbon dioxide or increased carbon dioxide in the blood. Salivation and respiratory secretion can occur. This is less problematic nowadays because nowadays non-irritating general anesthetics are more commonly employed. Cardiac arrhythmias and asystole can be seen. Fall in blood pressure can be noted, aspiration of gastric content leading to pneumonitis. Laryngospasm and asphyxia may occur, awareness, dreadful perception and recall of events during surgery. This may occur due to use of light anesthesia along with analgesic and muscle relaxant. Delirium, convulsion and other excitatory effects are generally seen with intravenous anesthetics. Ketamine পড়েছিলাম তো কি post operatively patient কিন্তু delirium হতে পারে. So seen with intravenous anesthetics, especially if phenothiazines or hyoscine have been given as pre-medication. These are suppressed by opioids. Fire and explosion, but nowadays these are not seen because of use of non-inflammable anesthetics. Can you name an inflammable anesthetic that was commonly used in the past? Ether. Complication of general anesthesia after After anesthesia, it can be nausea and vomiting, persisting sedation, এখনো recover করেনি, leading to impaired psychomotor function, pneumonia or atelectasis, organ toxicities like liver and kidney damage, nerve palsy because of faulty position, emergence delirium, cognitive defects. It can be observed in some patients, especially elderly, who have undergone general anesthesia, particularly for long duration. Now drug interaction. Now patient already on antihypertensive drugs, when given general anesthetics, BP may fall more marked. Neuroleptics, opioids, clonidine and MAO inhibitors, they can potentiate general anesthetic effect. Halothane sensitize the heart to adrenaline, leading to fatal arrhythmias. If a patient on corticosteroid is to be anesthetized, then supplemental 100 milligram of hydrocortisone should be given intraoperatively, so that severe adrenal crisis does not occur, as operation itself is a stressful procedure. Insulin need of a diabetic is increased during general anesthesia. Switch over to plain insulin even if the patient is on oral hypoglycemics. Now coming to the last topic today, pre-anesthetic medication. These are the drugs that are used before anesthesia to make it safe and less unpleasant. Now what are the aims of pre-anesthetic medication? Keno debo amra? Number 1, relief of anxiety and apprehension pre-operatively and to smoothen induction of anesthesia. Amnesia for the post-operative events. Number 2. Number 3, supplement the analgesic action of the anesthetics and potentiate it, so that less anesthetic drug is needed. They decrease salivation or respiratory secretions and vagal stimulation that may be caused by the anesthetic. Antiemetic action in the post-operative period, and they decrease the acidity and the volume of the gastric content, so that aspiration does not occur, and if at all it occurs, the damage is less or the severity is less. Now what are the now we will come the drugs that are employed in pre-anesthetic medication one by one. The first one is sedative anti-anxiety drugs, very common, benzodiazepines. Benzodiazepines like Diazepam or Lorazepam or Midazolam can be employed. Diazepam or Lorazepam, they are preferred for pre-anesthetic medication. Why? Because they smoothen induction, produce tranquility or sedation, loss of recall of perioperative event is seen, little respiratory depression or cardiovascular collapse, and it does not provoke the post-operative vomiting. They also counteract CNS toxicity of the local anesthetics. Midazolam is a good amnesic with potent and shorter lasting action. Promethazine is an antihistaminic that can be used here for sedation, anti-emesis and anticholinergic properties. They cause little respiratory depression. Now along with benzodiazepines, opioids can be used. Opioids like fentanyl, morphine or pethidine. Now morphine or pethidine allay anxiety, apprehension. They can produce pre and post operative analgesia, smoothen induction, reduce the dose of anesthetic required, and supplement poor analgesics or weak anesthetics. Post operative restlessness are reduced. What are the disadvantages with the use of opioid here? They depress respiration, and opioid cause basically constriction of pupil. So interfere with pupillary signs of anesthesia, may cause fall in blood pressure, can precipitate asthma, so not preferred in asthmatic subject, and tend to delay recovery. Lack of amnesia may be there, flushing, delayed gastric emptying, and biliary spasm. They also contribute to post-operative constipation, vomiting or urinary retention, all side effects of opioid. Tachycardia sometimes occur when pethidine has been used. Use of opioid is now mostly restricted to those having post-operative pain. Now coming to anticholinergics. Anticholinergics like atropine or hyoscine or glycopyrrolate, they are used. They have been used primarily to reduce the secretion, respiratory secretion. Now the need is infrequent nowadays because of use of non-irritant anesthetics. They also prevent, the main aim of their use is to prevent vagal bradycardia and hypotension. Hyoscine in addition produce amnesia and antiemetic effect, but problem is that delayed recovery, disorientation and emergent delirium. So hyoscine is not preferred. Glycopyrrolate, it's an anticholinergic with peripheral action and it does not cross the blood-brain barrier, so no central action. Okay. Anti-secretory action is more marked than atropine, while tachycardia is less marked. They are the preferred antimuscarinic in anesthetic practice. Now anticholinergics, antimuscarinics, they facilitate assisted ventilation. They used to, but problem is that they increase the anatomic dead space. They should not be used in febrile patients, as being anticholinergic they increase the temperature of the body of the patient. Dryness of mouth in the pre and post operative period may be distressing, and they are now mostly used intraoperatively when the need is there. Now neuroleptics, chlorpromazine, triflupromazine and haloperidol are infrequently used as pre-medication, nowadays not used. They allay anxiety, smoothen induction, have antiemetic action, but problem is respiratory depression. They potentiate respiratory depression and can cause hypotension and can delay recovery. These are the disadvantages. Involuntary movement and muscle dystonia can occur, particularly in children. H2 blockers or proton pump inhibitors, they are basically anti-acidity drugs. They decrease the acid production in the stomach. So they are used in patients who are undergoing prolonged operations or cesarean section or obese patient. Why? Because they are at more risk of gastric content regurgitation and aspiration pneumonia. Ranitidine or famotidine or omeprazole or pantoprazole can be given a night before, and in the morning of the operation day they benefit by they raise the pH of the gastric content and they decrease the volume of the gastric content, so that aspiration pneumonia can be prevented, or if aspiration pneumonia occurs the severity is less. It can also be used for prevention of stress ulceration. They are now routinely used before prolonged surgery. Antiemetics, metoclopramide, domperidone and ondansetron are used as an antiemetic in pre-anesthetic medication. Now metoclopramide, they reduce postoperative vomiting. It reduces the chance of reflux and aspiration. Problem with the drug, extrapyramidal side effects. So extrapyramidal side effects and motor restlessness can occur. Combined use of metoclopramide and H2 blockers are more effective. Domperidone is nearly as effective, but it does not produce extrapyramidal side effects. Ondansetron is a 5-HT3 serotonin receptor blocker. They are highly effective in reducing incidence of postoperative nausea and vomiting and devoid of any side effect, and they are the antiemetic of choice in anesthetic practice.